Hello, and welcome to the webinar on MASLD, also known as NAFLD or fatty liver disease, and NASH, which is the most serious progression of NAFLD and will have significant health impact. We're happy to have you with us for this informative webinar. I'm Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. Liver Health Foundation is a patient advocacy 501c3 nonprofit organization representing millions of liver patients in California and beyond, with a mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, and portions of Arizona and Northern California. As I mentioned before, tonight's webinar is about a liver disease known as NAFLD and NASH that has become epidemic in much of the world, similar to the epidemic of obesity and type 2 diabetes. New statistics show over 1/4 of the world's population live with this disease. The impact of fatty liver disease, non-alcoholic fatty liver disease in people with type 2 diabetes is now beginning to be fully understood. In the United States, greater than 70% of people with type 2 diabetes have hepatic steatosis, and many have NASH, which is a more severe form of NAFLD. Having NASH carries a significant risk of future cirrhosis, especially in the presence of obesity and type 2 diabetes. And it even increases the risk of hepatocellular carcinoma, HCC, or liver cancer. Patients with type 1 diabetes, particularly those with obesity, are also at risk for cirrhosis from NASH. It is believed that cirrhosis from NASH will still soon be the most common cause of liver transplantation in the United States. It is against this background that we embark on tonight's journey to learn more about NAFLD and NASH and understand guidelines for NAFLD screening, diagnosis, treatments, and monitoring. Now I have to put in our disclaimer. Please remember, information given by our expert is not a substitute for advice given by your own physician or healthcare provider. We do not endorse doctors, hospitals, medical centers, or any pharmaceutical company. This program has been made possible by an educational grant from Madrigal Pharmaceuticals and an educational grant from Global Liver Institute. We thank Madrigal and Global Liver Institute for their support. Tonight, we are honored to have some of the best hepatologists with us. It is my honor and pleasure to introduce Dr. Walid S. Ayub, who has generously accepted to be the presenter for tonight's program. Dr. Ayub, MD, FAASLD, AGAF, is the Professor of Medicine, founder and director, Autoimmune and Liver Disease Program, Associate Medical Director, Liver Transplant Program, Cedars-Sinai Medical Center, Department of Medicine, Karj Division of Gastroenterology and Hepatology, Comprehensive Transplant Center. Dr. Ayub achieved his medical degree at Creighton University School of Medicine, Omaha, in 1999, before taking up residency at UCLA West Los Angeles Veteran Administration Hospital. Between 2002 and 2006, Professor Ayub conducted fellowships in hepatology and gastroenterology at Cedars-Sinai Medical Center and UCLA, respectively. He then became clinical assistant professor of medicine at Stanford University until 2012, before moving back to Cedars-Sinai Medical Center, where he is currently Professor of Medicine, Director of Autoimmune and Cholestatic Disease Program, and Associate Medical Director of the Liver Transplant Program. Dr. Ayub is board certified in gastroenterology, transplant hepatology, and has been involved in several clinical trials investigating pharmacological therapies for liver impairments, cholestatic liver disease, and viral hepatitis. He is currently a primary investigator for clinical trials assessing the efficacy of novel agents in the treatment of MASH, primary biliary cholangitis, which we know as PBC, and primary sclerosing cholangitis, as again we know as PSC. Dr. Ayub has been an invited speaker at the digestive disease meetings and has moderated sessions at American Association for the Study of Liver Disease and the American Transplant Congress, discussing liver cancer therapies and management, as well as treatment of viral hepatitis and quality of organs in the solid organ transplant recipient. Dr. Ayub served as a member of the Hepatology Associate Committee of the American Association for the Study of Liver Disease. He is also a fellow at AASLD and a member of the American Gastroenterological Association, American College of Gastroenterology, and American Society of Transplantation. Dr. Ayub has held responsibilities as editor of Journal of Pancreatic Disorders and Therapy and a reviewer for a variety of journals, such as the American Journal of Transplantation, Liver Transplantation, Journal of Clinical Gastroenterology, Journal of Hepatology, and Digestive Disease and Sciences. Dr. Ayub's specialties include hepatology, hepatitis B, C, and D, primary biliary cholangitis, PBC, primary sclerosing cholangitis, PSC, autoimmune hepatitis, cirrhosis, portal hypertension, end-stage liver disease, acute liver failure, liver cancer, liver transplantation, and of course, fatty liver disease. Dr. Ayub is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Ayub, thank you for your support and participation. We are very happy to have you with us and are ready for your presentation.
Thank you, Farah, for this nice introduction. Let me share my slides. All right, can you see my slide?
Yes.
All right. But thank you again, everyone, for joining us today. And thank you, Farah, for the nice introduction. I feel humbled now after listening to my introduction that I have to give a very stellar presentation. We're going to talk today about the fatty liver spectrum and the new terminology for fatty liver. We call it metabolic associated steatotic liver disease, or MASLD, instead of the old NAFLD for fatty liver. These are my disclosure. And I'm going to be talking about the off-label use of certain drugs. So as Farah mentioned, fatty liver is a global disease, and MASH is seen worldwide with increasing prevalence. About 30% of the world population have fatty liver or MASH. But what's more surprising is a sharp rise in the prevalence of fatty liver among children, where it's estimated about 7.6% of the world children population already have fatty liver. So that's a problem that's going to increase with time in prevalence and will have a significant impact on our healthcare system. So if we look at in the United States, in 2016, 25% of adults have fatty liver or MASLD. So if you look at numbers that correlate to about 65 million people, and it's estimated that number to double by 2030. And if we look at the severe form of fatty liver or cirrhosis, that number will lead to 3 million people in 2030. So it's not surprising that many studies have shown an increased cost of caring for these patients with time. For example, the incidence of complication from cirrhosis attributed to fatty liver is expected to increase by 170%. The incidence of liver cancer associated with fatty liver is also expected to increase by close to 140%. Not to mention the dollar amount that's going to be spent on this disease is expected to double, if not to triple, by 2030. And this is not a problem just unique to the United States. Even in the world, if you look at France, Germany, Europe, or Asia, the prevalence of fatty liver is also expected to increase during that time. So the increase in health cost implication, complication to the patient, mortality is expected to increase in the whole world, not just in the United States. What we know, even if a patient have a simple fat in their liver without any complication, they are at a higher rate of mortality compared to people without fatty liver. So if you look at this graph, the bottom line, the orange line is a general population. And then as you go up, the green is a patient with simple fat on their liver without liver damage. Then as the fat becomes inflamed, the green, the mortality go up. And then if they develop advanced fibrosis, then the mortality even go higher. And when they reach cirrhosis, the pink color, that becomes significant incidence of mortality just attributed to fatty liver. So fatty liver is not a benign disease. It has to be addressed at every stage. So it's not surprising in the United States that the MASH or fatty liver is a leading cause of patient on the liver transplant waiting list. And if you look among patients who receive a liver transplant, it's a #1 cause in female and second to alcohol in men, and soon to be surpassed, to surpass alcohol in men. So how do we look at fatty liver? So the way I consider it, it's a spectrum of disease. We have the general umbrella of fatty liver, or what we call medically steatotic liver disease, and it's broken down into 5 categories. One, the one we're talking about today, MASLD, or non-alcoholic fatty liver disease, the new term metabolic dysfunction associated steatotic liver disease. And then you have the alcohol-related liver disease, and the box in the middle, the larger box, is the one that's people with fatty liver from both etiology, whether alcohol or non-alcoholic cause. And then you have the other 2 categories, a certain agent known to cause fatty livers, such as drugs, certain genetic disease, or we have a small category that we don't know the cause of the fatty liver. And we believe this is more of a burnout fatty liver from the past. And what I put at the bottom is, the amount of alcohol usually we have in our life. So, 1 drink of standard alcohol is equal, 1 beer, is about 12 ounce. Then malt liquor is 8 to 9 ounce. Wine is 5 ounce. And, hard liquor, 1.5 ounce. So you could see the amount of ounce of alcohol is not the same across. The amount of alcohol is different among the different form of alcohol. So when we talk to a patient, usually we try to figure out what kind of alcohol they have, if alcohol is contributing to their fatty liver, and we do some education. Moving back to non-alcoholic fatty liver disease, or MASLD, this is the spectrum or the natural history of patient with fatty liver. You have patients who have a simple fat or steatosis. Then when they develop what we call cardiovascular factors, so this is usually include the elevated blood pressure or elevated cholesterol, hyperlipidemia, morbid obesity, or insulin resistant, then the fat gets activated. And this is where they develop steatohepatitis, or inflamed fat. The medical term is MASH on biopsy. And once they hit this stage, they move into a different category. They are at a higher risk of progressing to cirrhosis at a faster rate, and they are also at risk to develop liver cancer with time. What's unique about steatohepatitis or MASH is patient could go directly from steatohepatitis to liver cancer without going through cirrhosis, which is usually what is seen with other cause of liver disease that progress to cirrhosis and liver cancer. And in some study, it has quoted up to 20% of patients could develop liver cancer without going to cirrhosis. So it's quite a scary number, but more study is waiting to confirm that number. But we know there is a higher incidence of liver cancer in patients with NASH or MASH without cirrhosis. The other important point is how do we stage or grade the damage that the fat has caused on the liver cell. The way we measure it is by measuring what we call the scar tissue, the collagen deposit. So if you look at my slide on the left, there is a blue line around the white cell. This is called the medical term perisinusoidal fibrosis. So very thin line or very thin scars that form between the fat cell or the liver cell. And as more scar tissue deposited, the higher the stage become. So if you're moving from left to right, as more blue lines form, you move to stage 2. Then when you have a near complete formation of a nodule, so then you move to stage 3. And then stage 4 or cirrhosis, where you have a liver tissue, normal liver tissue surrounded by a lot of scar tissue, thick bands of scar tissue. And as I mentioned earlier, when a patient hit F2 or stage 2, they are at a higher risk to move rapidly to stage 3 and stage 4. What's difficult in managing a patient with fatty liver is the progression is unpredictable. Some patients progress very rapidly and other progress at a lower speed. So we treat everyone the same, assuming everyone's going to progress rapidly. So what do we know about the causes of NASH or MASH? So I simplified the pathophysiology of MASH. So if you look on the top in the middle, we have the fat cell. We call it the adipose tissue, the adipose cell. When this cell sees a large amount of fat coming from the diet, or a large amount of glucose or sugar coming from the diet, then it gets activated. The liver cell, when they see a lot of glucose, they start forming more fat. So you have more fat deposit on a already existing fat. So the fat cell get overwhelmed and get activated. And that will lead to development of what we call insulin resistance, the hallmark of fatty liver or MASH. When insulin resistance develops, patients at risk to develop a lot of medical problems. So there's a higher incidence of high blood pressure or hypertension, diabetes, cardiovascular disease, hyperlipidemia, and development of fatty liver or MASLD. This usually also requires presence of certain genes. So we know certain ethnicities, such as Hispanic, has a higher prevalence of fatty liver. Caucasian have a higher incidence, while African American have a lower incidence. And we know insulin resistance is also present especially in Asian who tend to be not obese. We call it lean NASH, but all of them usually the hallmark is that insulin resistant and adipose cell activation that lead to complication of NASH or fatty liver. So to look at it in a different way, we know now that fatty liver or MASLD or NAFLD is a part of a multi-system disorder where insulin resistance is dominant. So it's not surprising that patients with NAFLD also tend to have other disease or symptoms of this multi-system disorder. We know there's a good association, increased incidence of obstructive sleep apnea in patients with NAFLD. They tend to have more gallstone. In women, there is more polycystic ovary syndrome incidence. But very important, we know patients with fatty liver or NAFLD have a higher incidence of cardiovascular disease or deaths. There's many studies, so overall there is 40% increased incidence of cardiovascular complication, including death. There is certain malignancies that becomes more pronounced in patients with fatty liver, especially, liver cancer, stomach and pancreas cancer. So whenever we see a patient with fatty liver, we usually try to look for these other associated disease with fatty liver. So who are the patients with fatty liver walking around in the world? So if you look at patients who are obese, and obesity is defined by a body mass index over 30 among Caucasian population, Hispanic, and non-Asian population, up to 90% of them, of these patients or these people have fatty liver on screen. Up to 70% of patients with cardiovascular disease, these are patients who either had a history of stroke, hypertension, heart attack, have a fatty liver. Hypertension, up to 70%. Diabetes, 70% presence of NAFLD. So as you could see, this is quite common manifestation. I would say this is a high number of risk factor for development of fatty liver. So we know that diabetes is the most important one. When patients have diabetes, they tend to progress at a faster rate to deposit more scar tissue in their liver. We believe that the inflammation in the liver is more pronounced in a diabetic patient than non-diabetic patient. There are many studies that prove that, and these are, one of them, that patient with diabetes, if you compare it, the green to the orange line, you could see that the orange line falls below the green line, indicating that the progression of fibrosis or damage in the liver is more pronounced in the setting of diabetes. So how do we grade the severity of patient with MASH? Do we need to do a biopsy? The answer is no. We have other ways to measure it. We call it non-invasive testing. And those non-invasive testing measure usually assess the level of scar tissue or fibrosis, or plus or minus the level of fat or steatosis in the liver. So what are they? So we have broke them down into three categories. We have what we call the biochemical based testing. So these are based on blood test results that every person have them. Usually a liver test, platelet count, put into a formula. It will give us a score, and that will stratify the patient about the risk of having advanced liver disease or fibrosis or cirrhosis. We have a commercial test done at Quest or LabCorp called the ELF score. That's a new kid on the block. And we also have radiology-based testing, ultrasound-based. So I listed the three common ones used: the FibroScan, the Hepatis made by a company called Mindray, and VeloCore. We also have a fancier test called MRI elastography. These tests, the ultrasound-based, look at a small portion of the liver, about a square of the liver, while the MRI gives a global assessment of the whole liver. So if you look on the right side at the liver, I hope the squares are visible. So you could tell, if you could see my cursor, this is the area that the FibroScan or Hepatis or a VeloCore will look at, while the MRI will look at the whole liver and give us an average of the fat and the scar tissue in the liver. So these are some examples of biochemical testing. There's something called the FIB4, APRI score, the more complicated test, and the imaging, ultrasound-based imaging, the FibroScan and the Mindray is quite simple, 5 to 10 minute test. It gives us two readings, the orange one that says the level of scar tissue, and that number correlate with the level of scar tissue in the liver. The blue number, amount of fat in the liver. So we give us a grade of the scar tissue and the fat in the liver. The MRI, as you can see, it's a heat map. So it gives you a different color of the liver. So over here, they trace the liver. And you can see there's a yellow, red, green in that image. Red is a sign of a lot of scar tissue. So this is a very sick patient, very sick liver. While the blue or the magenta color is more of a healthy liver. And as you move from magenta to red, then the liver becomes sicker. And another advantage of the MRI is also it could measure inflammation, and this has been validated. So, there's a software used with the MRI machine that give us indirect measure of the liver inflammation called CT1, and that's been validated in many studies. So we have many measures to assess the level of damage to the liver without doing a liver biopsy. So now we made a diagnosis. How do we manage the patient? So this is a complicated slide, just to mention that we usually, the evaluation start at the primary care level, where if a patient have, diabetes, or they have two risk factors for what we call metabolic disease, elevated blood pressure, cholesterol, or obesity, for example. So these patients needs to be considered for evaluation for fatty liver. The way we do that, we use as a non-invasive testing, the one I mentioned. The simplest one is called the FIP4. It's based on a common lab test ordered on most patients. And depending on the score, will determine the next step. If it's a high score, over 2.67, these patients are at a high rate to have advanced liver disease. If it's a low score, less than 1.3, these patients are okay. They could be monitored every 2 to 3 years. If it's in the middle, we usually need to do a second non-invasive testing. Over here, they use the liver ultrasound-based elastography, and depending on the level, will determine the risk of the patient. So less than 8 is a low risk. Over 12 is a high risk. In the middle, this patient needs to be followed carefully. So once we made the diagnosis, then the management number one is make sure we counsel patient on lifestyle intervention, and we'll talk more about it. Weight loss becomes important, especially in an obese patient. Pharmacotherapy is new now. We had all the medicine we use. They don't work as good as a current regimen, and we'll talk more about it. But very important, we need to counsel patient as a primary doctor or referring provider about the importance of addressing the cardiovascular risk. Because, as you mentioned, 40% of the patients die from cardiovascular complication and diabetic care and diabetes. So lifestyle intervention, usually, the way I look at it, 4 categories. One is control what the patient eats. So we usually ask for caloric reduction, 1,000 calories a day. Then other important part is limiting the fructose-enriched beverages, so the sodas. So diet or non-diet has a lot of sugar, so should not be on it. Artificial sweeteners are another one. Then you encourage them to lose, 5% of their weight or more. Usually 7% is what I ask for. 10% is ideal. And exercise is proven. You need about 150 minutes a week minimum. So that's half an hour a day, 5 days a week. And no alcohol consumption, because we know alcohol speeds up that progression to scar tissue formation. More on the diet. So I like the slides from Dr. Michael Charlton. He allowed me to use it. We usually increase what we call the macronutrient or the bad diet. So these are the carbohydrate, the fat and fatty acid, so fried food. And the source limits the red meat or what I call the bad protein, increase more of the fish and the chicken. So this is what we call a restrictive diet. And when the patient go for weight loss surgery or bariatric surgery, this is one of the effects. Patient cannot tolerate these compounds. They will have a side effect when they eat a high fatty meal or high rich sugar meal. And you want to increase a good ingredient in the diet. So usually that's why vitamin E has been used and showed to have some benefit. Other ingredient in the diet that proven to be helpful in fatty liver to a certain extent, zinc, copper. But you could get all of these if a patient follow, Mediterranean diet. Mediterranean diet is rich in all of these. So I tell my patient, give them information about Mediterranean diet, tell them to cut down on their carbohydrate and fatty meals. And if you do that, then you reset the inflammation in that adipose tissue or fat cell, and therefore you will lead to less insulin resistance and complication from it. Now, realistically, weight loss. As I said, I usually ask for 7% or more, because that number has been linked on biopsy with the resolution of the inflammation in the liver. And if you push it to 10%, you will get the bonus of scar tissue regression, or you melt the scar tissue from the liver. Realistically, less than 10% of the people are able to achieve the 10% loss. Majority of the patient, fall into about 5% or less category. But it's always important to remind the patient that lifestyle change, diet and exercise, you could achieve, loss of fat in about, 40% of the patient, which is quite good, 40 to 60%. the old medicine we used before, vitamin E, and we have a diabetes medicine called pioglitazone. There are a lot of side effects, so we're not using them much as before. High dose vitamin E has been linked to stroke, prostate cancer, heart attack in the old literature. Pioglitazone, weight gain, heart failure, cousin to pioglitazone was pulled off the market. So they are not clean drugs. So I don't like to use them a lot in my clinic. The good news is we have many drugs being developed now that address different pathway in the mechanism of fatty liver. The one I circuit is called THR, thyroid hormone receptor beta agonist. It's called resmetirom. This is the one that was approved recently. But we have many other drugs in the pipeline for the development of fatty liver in different stages of development. So the future looks bright for patients with fatty liver. We also have medication used for management of diabetes. These are what we call the GLP-1 agonists. So the famous ones are semaglutide or Ozempic. But we also have tirzepatide or Mounjaro. These are shown in studies to slow down the inflammation in the liver, but they are not good at reversing the fibrosis or the scar tissue in the liver. So it's good for patients with early stage, but not for advanced stage. Which brings us to today's last month in April, is medicine called resmetirom or Resdifra was approved. It's the first approved medicine that was waiting for more than 30 years for treatment of fatty liver. It's indicated for patients, with fatty liver and F2 to F3 fibrosis, so medium to moderate level of scar tissue in the liver. And in the clinical trials, that medicine is shown to reduce inflammation by 30%. And reduce scar tissue formation by 26%, where patient improved by one stage. They went from F3 to F2 or F2 to F1. So now we have hope for patients with fatty liver that we could give them a safe medicine to reverse inflammation and scar tissue formation. The added benefit of this drug also, which is not commonly advertised, it also lowers the lipid profile. It addresses hyperlipidemia in patients with hyperlipidemia and fatty liver. So, it's a good medicine that I think is going to have a great impact on the course of fatty liver, and it's a great help for our patients. So in summary, when we management of fatty liver, a lifestyle change, I did not talk about it, but black coffee is very good for the liver. We reduce the fructose. This is artificial sweeteners. Macronutrients, fatty diet, usually you want to avoid. So you want to have a low to moderate fat intake, a low carb diet, Mediterranean diet. It's been studied extensively in fatty liver with good outcome. Alcohol, usually I ask my patient to stop it because of implication on liver itself. Calorie, 1,000 calorie a day activity, as I said, half an hour of exercise a day. And if after lifestyle modification, then now we could use resmetirom or Resdifra. It's approved for patients with F2, F3 fibrosis and fatty liver. But as I mentioned, we have a lot of drugs coming up in the pipeline for patients with fatty liver. And that will bring me to the conclusion of my presentation. Thank you for your attention.
Thank you so much, Dr. Ayub. This was quite an eye-opening information, and I already have several questions for the group when we start our roundtable discussion. But let's just wait for that. So now we're going to start the second half of the webinar, the roundtable conversation with our guest experts who will talk about NAFLD and respond to your question. Please remember, you can post your questions or comments on the chat or Q&A tabs. So it is my pleasure to introduce now Dr. Edward Mena. Dr. Mena is Medical Director, Pasadena Liver Center, Director, California Liver Research Institute, or CLRI. After obtaining his undergraduate degree at UCLA and medical degree at USC, Mena completed his residency at White Memorial Medical Center when he became the chief resident.
Hello, everyone. I think we lost Farah, so I'll go ahead and dive in. I'm not sure where she left off, so I'll just continue with introducing Dr. Mina. He established a collaboration with Cedars-Sinai and USC liver transplant teams that facilitate the management of liver cancer and liver transplant cases. This revolutionary program created an outpatient treatment center for hepatocellular carcinoma patients, bringing together patients and doctors that provided a more efficient process of administering treatments. In 2016, Dr. Mena established a research institute called the California Liver Research Institute. CLRI is a nonprofit organization focused on the advancement of treatment and curing of all forms of liver diseases. Since its inception, Dr. Mena has coordinated over 20 clinical trials. Under Dr. Mena's directorship, the Pasadena Liver Center and CLRI have become one of the busiest and the most successful liver centers in the Los Angeles area. In addition to overseeing both his clinic and research institute, Dr. Mena is a tireless advocate for the awareness of liver disease in the community. He coordinates awareness programs for the Latino and Asian communities that encourage the screening of liver diseases such as fatty liver disease, cirrhosis, HCC, and hepatitis C and B viruses. Over the past 20 years, Dr. Mena has had many rewarding experiences mentoring residents and medical doctors at all levels and provides opportunities for them to collaborate with him on various publications and research studies. In 2019, Dr. Mena was awarded the Hispanic Health Leadership Award by the National Hispanic Health Foundation in recognition for his strong leadership in the health community. In 2020, Dr. Mena was awarded the Healthcare Visionary Award through the American Liver Foundation. Also in 2020, Dr. Mena was awarded the Fellowship of the American Association for the Advancement of Liver Disease. Dr. Mena is a member of the Liver Health Foundation's Medical Advisory Council. Welcome and thank you for your participation. And now it's my pleasure to introduce Dr. Bishoy Yani. He is Program Leader, Hepatology, UCLA Medical Center in Santa Monica. And he specializes in general and transplant hepatology and focuses on treating patients with a wide spectrum of liver disorders. He is well versed in the treatment of hepatitis C with the new direct-acting antiviral agents. He cares for patients with liver cirrhosis and its spectrum of complications. He also cares for patients before and after liver transplantation. His research interests include non-alcoholic steatohepatitis, hepatocellular carcinoma, and viral hepatitis B and C. And I hope I pronounced those correctly. Dr. Yani completed his internal medicine residency at Keck School of Medicine and County Hospital of USC. Following his internal medicine training, he served as the inaugural transplant hepatology hospitalist at Kaiser Permanente Los Angeles Medical Center for 1 year. He then completed his gastroenterology and hepatology fellowship at Kaiser Permanente Los Angeles Medical Center. Dr. Yani moved to UCLA as the inaugural transplant hepatology fellow, where he completed his training. He is board certified in internal medicine, gastroenterology, and transplant hepatology. Dr. Yani has presented research at multiple national and international societies, including AASLD, EASL, Guild, and DDW. Dr. Yani is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Yani, thank you for your support and participation. And next, I'd like to introduce Dr. Rita Nadeem. She's currently practicing in a transitional licensed MD role at Arizona Liver Health. She began her journey in hepatology training in August of 2022. Her area of focus and interest is metabolic liver disease. Dr. Nadeem has an immense passion for MASLD-MASH and leads a group in a retrospective clinical research in this field at her practice. Over the past few days, we've received questions from the audience as well as those who couldn't be with us tonight. So we've submitted those to our presenters to review and respond. However, you're all welcome to post your questions in the Q&A or chat, and we will monitor them. So to start the roundtable, we'd like to pose the first question that was repeated several times as our audience sent their questions in, and it is, what is the prevalence of MASLD-MASH in various ethnic groups such as Asian, Hispanics, Middle Eastern, African Americans, and others? Dr. Ayub, would you like to start us off?
Sure. As I mentioned in my presentation, 30% of the world population have MASH. There's a higher incidence in Hispanic patient compared, to other race, to other ethnicity in the United States. In epidemiologic study, up to 30% of the patient, there's a 30% incidence of fatty liver among Hispanic patient. Similar number or slightly less in Caucasian. Middle Eastern, there is not great studies about incidence of fatty liver in Middle Eastern, but it's estimated also to be about 25 to 30%. Blacks is very minimal, less than 5%, according to the recent studies. Dr. Mena, I see a lot of Hispanic. Do you want to shed more light on your practice, Ed?
So it's funny, I was thinking my practice, when I look at my fatty liver disease patients, I would say the majority, almost 80% are Latino. Part of that is, the area that I practice, which is in Pasadena, and of course our referral base, but I see every ethnicity, Latino, Asians, of course. Not so many, like you mentioned in your lecture, African Americans. I think that's the one I see the least, but for me, the majority is going to be the Latino. And we've been talking about certain genetics, and there's a certain gene such as PNPLA3 that's associated with fatty liver and may have a higher incidence in Latino patients.
Dr. Yanni, do you have more information about Middle Eastern population and fatty liver, and Dr. Nadim?
No, I think that there isn't really enough studies in that region, and I think the prevalence of fatty liver is highly underestimated in that region due to the lack of studies. I think 20 to 30% really doesn't do the numbers justice. And more recently at the most recent ASLD meeting, when they showed that world map of the prevalence of fatty liver, some of the highest prevalence areas were in the Middle East. I think in certain areas of Egypt and Africa, it's just all red, very similar to some areas in South America, and some areas with the Latino population. But I think it's the prevalence of NAFLD is really underestimated, maybe not just in the Middle East, but worldwide, but specifically in that area.
Sure. I mean, Dr. Nadine, in Arizona, what kind of population, what do you see?
So very similar to what Dr. Mena was saying, we have a large patient population of Hispanics, so we do see a lot of MASLD-MASH cases in that cohort. And I do kind of want to echo what Dr. Yanni was saying. I think certain groups are we're underestimating the disease burden. South Asians, to be a little bit more specific, they have a high disease burden when it comes to diabetes and high cholesterol levels, and these patients are just not being screened, and we just don't know. And so I think we need to study these populations a little bit better, but I agree with the stratification that you laid out. That's what we generally tend to see in our practice also.
Yeah, in other groups that also get ignored in study are Native American. The Native American population have a high incidence of diabetes, alcohol use, cardiovascular disease. So there's a smaller study that showed the incidence, the prevalence of fatty liver in that population, as high as 40–50%. Common question I noticed as a question Pharaoh asked. So when you have a patient in your clinic with fatty liver, how would you counsel them about lifestyle change? So we could start down, panel, start with Ed and move down.
So, with respect to lifestyle changes, we always try to discuss diet and exercise. And then the patients, I love my patients because they go, "Oh, Dr. Mena, how could I be overweight? I just have a little bit of chicken and I have a salad," and they give you the best diet they've ever had. But I always say, okay, let's be realistic. And I always kind of really offer them the Mediterranean diet. And I always try to do a calorie count. And I always try to stress the importance about exercise, because you need to have some form of exercise in your life to have that balance of diet and exercise for fatty liver. And if it's difficult to lose weight, and I think they're appropriate and have, let's say, simple steatosis, then I do offer a GLP-1.
Okay, very good. How about you, Dr. Nadim, in Arizona? How is it done?
So similar approach. I think when I meet a patient for the very first time, it's really important for me to kind of understand where they're coming from and where that denial lies, right? So if I understand that they're not quite clear on what they're eating, then I take a few moments and I go through and I review their day with them. Obviously, we don't have a lot of time to go into the nitty-gritty, but in general, like, you pick up on some cues. And if I find that my patient is just really not ready to do a fully restrictive diet, then I try to take a step back and I connect their comorbidities for them. That's been really helpful in my approach, is like identifying, oh, you have diabetes and you have cholesterol problems, look at your triglycerides. And then bring in the diet piece and say, hey, if we could just address this one area, it would correct 3 things instead of just one. And when you teach a little bit, kind of what you were doing earlier, but in very simple terms, like, this is not a benign disease, and all of this is connected. And if we can change, you make baby steps towards it, and then kind of empowering them with, find the protein is what my little spiel is for every single patient. Find your protein in your meal and then design the rest of it around there. And then if you're going to have a little bit of carbs, so be it. You'll do better when they're balanced, as opposed to just eating the way that you're used to eating. And it's overwhelming for them to make those changes all at once. So bite size, baby steps, sustainable change is kind of what I try to emphasize.
Very important. So Dr. Yanni, so one of the questions said, how do I know that my condition is worsening? What signs and symptoms should I be looking for?
Yeah, so, fatty liver is one of those diseases that's usually pretty silent. So, there are some very very mild changes that patients can sometimes describe, like fatigue or like feeling sluggish or whatnot. But unfortunately, we won't know that disease progressed unless the patient is under the care of the appropriate care team, getting the appropriate studies with either non-invasive fibrosis testing and blood testing, unless it's too late. So unfortunately, when it's too late, patients will develop the full spectrum of decompensation from liver disease, such as jaundice, encephalopathy or confusion, swelling of the abdomen with ascites. But at that point, the patient needs to be under the care of pathology and maybe even consider transplantation. So the best way to know if the disease is progressing, it takes quite a vigilant approach between the patient and the doctor. And some education, which if there are risk factors, those risk factors should be identified by the patient's physician, and start to identify whether they are at higher risk or not for progression. And as you mentioned, Dr. Ayub, very eloquently in your talk, those risk factors include diabetes, hypertension, sleep apnea, dyslipidemia or high cholesterol, obesity. So if a patient has those risk factors, it would be a good idea to look for fatty liver, and utilize some of the non-invasive testing, like the FIB4, initially based on blood tests, followed by FibroScan or some form of fibrosis testing, to see where they stand on the spectrum. So I always tell my patients that unfortunately, once you start noticing symptoms, it may be a little bit late in the game, where there is jaundice, ascites, encephalopathy, and what's not. So.
In my practice, I emphasize to the patient, fatty liver is a silent disease.
Yes.
By the time it gives you signs, it's already a little bit late in the game. So we have to do prevention and monitor the progression of the disease. And I tell the patient, you're in charge. You are in charge of make sure your blood pressure is under control, your diabetes under control, you get your care with your primary doctor, you exercise. Because if you don't, then the disease is going to take over and affect your liver in a negative way. All right, now here is the most common question we see in clinic. Doc, I'm already underweight, but I have fatty liver. Why? So Ed, what do you tell your patient?
Well, there are certain patients that have lean fatty liver, but I think it's also dependent on what's the definition of weight. But regardless of where weight is, and you talked earlier about BMI, but this is a metabolic disorder. So even though your weight may be, I'm going to say, let's say below a BMI of 25, do you still have components of the metabolic syndrome, such as hypertension, dyslipidemia, in particular, a high triglyceride count? So I always tell my patients, those are other factors that we have to see other than just weight. And like you mentioned earlier, diabetes and the marriage between fatty liver is just so strong.
Rita, any different approach or anything to add?
Pretty similar to what Dr. Mena said, but I also kind of highlight that it is also very diet dependent. So let's talk about what are you eating. So you can be very skinny and have maybe not eating a whole lot of excess calories, but if your diet is heavy in carbs and sugars, like you're gonna have a fatty liver. So I do tend to bring that up too. And then the Asian population, particularly, where their diet is so heavy in rice and bread, generally noodles, that sort of stuff. So highlighting those things to them as well.
Yeah, I think as you alluded eloquently, education and having the patient in charge is very important in managing, especially what we call lean NASH or lean NAFLD. How about exercise? So, Doc, I don't have time to exercise. What's your approach, Dr. Yanni?
Exercise is important, but I emphasize the diet a lot. And there was a study initially when they did the biopsies. I think it came out of UC San Diego, if I'm not mistaken, where they randomized the patients into one of three arms, where they looked at diet alone, diet and exercise alone. To reduce body weight. And very interestingly, patients who just had a really strict diet and lost 10% of body weight did the best in terms of losing the inflammation in the liver and some regression of fibrosis after 10% of body weight reduction. So exercise is important, but it doesn't have to be strenuous exercise. It doesn't have to be, we don't have to train for marathon running. It could just be light walking every day and just to increase the basal heart rate. But I emphasize the diet a lot more. And I think as most of us would agree that one of the longest discussions during liver clinic is the dietary discussion. We discuss about I usually discuss two things. I discuss with the patients the type of food and the amount of food, because they're both just as important. So the type of food, like we've talked about, the lean proteins, the low carbohydrates, and the low saturated fats and fried foods, but also the amount is very important. So if
Portion control.
Portion control, exactly. Yeah.
So one thing, there's an older study, that showed that, diet is a base of the pyramid. But if you want to increase your rate of success by 15% to get close to that 40% or 60% success rate, you add the exercise. So 2/3 diet, 1/3 exercise is what I emphasize. And if you're having difficulty with diet, then you got to introduce the exercise to make up for that. Now, there was a few questions about the recurrence of fatty liver after transplant. So I'm going to take that one. Usually 25% chance of the fat coming back after liver transplant. And it's the same risk factor as patient without a transplant with the extra additional factors of immunosuppression. The immunosuppressive drug increase the chance of development of insulin resistance and diabetes. So yeah, transplant patient has to be more vigilant in modifying the risk factor with diet and exercise. Another question that came up was, I have fatty liver. Does my sibling have a higher chance, or my children have a higher chance of fatty liver? Dr. Mena, you're shaking your head. You have an answer.
The funny part is when I see some of these patients for fatty liver, and I have the grandma, the abuelita in the room, then I see the daughter, and I see the grandson, and they're all a little overweight. And so yes, there is, I think, not only what we're eating in the home, of course, there's a genetic predisposition, but I think it has to do with lifestyle and the foods that we're eating in the home, and that's what's causing central obesity in these families.
There was
I have a question. May I ask? Sorry, I was gone for a long time.
Yeah, let me stop you for a second. Let me just finish this question, and then we'll get to you to give us a chance. There was a study that showed the patient with advanced fibrosis and fatty liver, 19% of their first-degree relatives, so these are sibling and children or parents, have an incidence of concurrent fatty liver problem. So when I see patient with fatty liver, I always ask about family history and educate the patient, you have this problem, there is a 20% or more chance of your children having this problem. So it's very important you educate your family member against fatty liver and to work as a family in managing fatty liver. So you're not doing this just for you, but also for people living in your house. Sorry, Farah. Back to you.
Oh, no. I'm sorry I jumped in. I was gone for a while, so I don't know what was asked. But one of the questions that was asked at least 5 times from 5 different people was that we have hearing all the time about obesity being the cause of NAFLD. I have been skinny all my life, and I have developed.
We had that question answered, Farah, while you're away. Dr. Mena answered eloquently in a nice way.
Very good.
There's many factors at play, and certain genes are more prevalent in certain ethnicities that will increase the chance of NAFLD and the importance of metabolic disease.
That's great. I will go back and review it. Did we talk about Dr. Ayub? You mentioned that the children's NAFLD, which is something that's becoming very unfortunately spread in the United States. Did we talk about that, children and NAFLD, and what we can do?
I think that's more of a discussion to a pediatric hepatologist who have more data, concurrent data. But in the adolescent, we see, it's quite prevalent, and the treatment is similar to the treatment of adult in a way. With certain nuances, there are certain medicines that are being studied now in children to address NASH. And to my review, it's somewhat similar to what's done in adult. And I wonder if the other panelists have more input about it.
Dr. Mena, is this prevalent in minority groups more than Americans, or kind of the same?
I see, Latinos, especially younger Latinos, teenagers with fatty liver, but I think it's just because America's getting fatter. The question is, what are we going to do about that? It's a tough question to answer.
Dr. Yanni?
Oh, can you hear me?
Yes.
Yeah, so, obesity is becoming prevalent, more prevalent in the US. I would agree that this is a better discussion for a pediatric hepatologist. But theoretically, when obesity increases, some studies show that you can see NAFLD and NASH as early as in patients that are 10 years old. And you know, how to deal with that is a big discussion, and I think I would agree discussion with a pediatric hepatologist would be ideal.
Yeah, I think the future for NASH, you know, these children are aging. And, you know, within, you know, some studies show you could develop the cirrhosis within 10 years of diagnosis of NASH. So just imagine somebody who's 10 with NASH already. By the time they become adult, they are at a higher risk for developing cirrhosis. So it's very important to address this issue with a pediatrician and a pediatric hepatologist at an earlier stage to prevent or slow down that progression. You know, we know there's an increased incidence of diabetes in children now, and many studies showed direct link to Western diet, fast food diet, with a higher risk of development of diabetes. So there's many modifiable factors we have in our Western society that we could target to impact the future of children with fatty liver.
So the first one is, can you describe the role of pharmacological therapy for weight loss on the part of gastroenterologists, hepatologists? Are more GIs and liver providers now getting comfortable prescribing, or how is this handled in your practices?
So Dr. Yanni, you want to take that one?
Sure, happy to. So, you know, up until recently, there were no FDA-approved medications for the indication of fatty liver. Yes, we know that weight loss is important and would be very helpful, but because the medications for weight loss are not FDA-approved for fatty liver, it was kind of limiting for the hepatologist. So if patients had other indications that would qualify them for medications such as the semaglutide agonists, such as the phentermine, you know, and those things that will help with weight loss, then in conjunction with their primary doctor and endocrinologist, these things can be considered and see if you know, if insurance will allow for it. As part of the good quote unquote side effect of this medication, which is weight loss, you see some improvement and resolution of the fatty liver, but again, not indicated solely for fatty liver. So approximately 2 months ago, resmetirom was approved for fatty liver, which is a thyroid hormone selective beta agonist for the liver cells, which increases the metabolism of fats in the liver cell itself. And it helps about 25 to 30% of patients reduce fat and regress the fibrosis. So as it stands, that is the only FDA-approved fatty liver medication at this time. You know, in my practice at least, if we are considering weight loss medications, I do that under the discretion of the primary doctor and the endocrinologist as a multidisciplinary approach to help reduce the risk factors that cause fatty liver.
How about you, Dr. Nadim? Do you recommend Wegovy, Zepbound for weight loss in patients with fatty liver?
So kind of like what Dr. Yanni had mentioned, I do try to take a coordinated approach with their PCPs and endocrinologists. But now with Wegovy and Zepbound being approved for weight loss, you know, every once in a while, in those patients who are having a lot of difficulty and can't quite get it, we'll try to write for it. And minimal success usually doesn't come back very promising, but we've had some luck getting it approved for weight loss specifically. But what I tend to like to do more so with these patients who are interested in being on GLP-1s is teaching them that I would like for them to use them as training wheels to really change their lifestyle and then the way that they approach their diet and what that relationship with food is. And while it's going to help them lose weight, but if they go off of it, they will gain it back unless they've used it in that capacity where they're training themselves to eat better instead of continuing with those habits. And when they're eating, very small portions, still eating quite bad. So teaching them along with prescribing it is really important, because otherwise they just think it's a miracle drug and they've lost weight and everything is fixed, and they don't have it for 6 weeks and they gain the weight back, and we're back in that pendulum of not really addressing the root cause.
How about Pasadena, Ed? How do you address it, or do you prescribe it?
I do write a lot of the GLP-1s, mostly Zepbound over semaglutide, but I only do it on patients who have simple steatosis with no evidence of fibrosis. But like Dr. Nadine said, I think I've written 60 prescriptions, and of that, only like 6 have been filled. So it's very difficult to get them approved by the insurance plan. But I think it's a temporary measure. They have to have some lifestyle modifications. And remember, though, when the patients stop the medication, 75% of them are going to gain the weight back.
That's so true. How Ed, since you prescribe so much of that medicine, how do you counsel them about side effect? Because as you know, with Rezdiffra now approved, there is a common side effect between both drugs.
Yeah, so we always comment on, discuss the side effects, which are typically nausea, vomiting, abdominal pain, diarrhea, constipation. But it's really important that when the patient are on a GLP-1, and we see this when we have the clinical trials with GLP-1, they have to eat 5 small meals a day. You cannot eat your old eating habits of a huge lunch and a huge burrito for dinner. All of that needs to change on a GLP.
Very good, because the side effects are quite notorious once they hit, and a lot of people will decide to stop the medicine just because they can't handle the side effect.
Especially nausea.
Yeah, the other important point. I'm not sure if you guys came across it at the latest big liver meeting in Europe. There was a presentation by tirzepatide or Zepbound, looking at the effect on fatty liver. It has an effect on inflammation, calming down the inflammation of the liver, but resolving the scar tissue in the liver, the signal was not as strong. So they are not, in my mind, so far that we have a better proof or evidence. These drugs should be used cautiously in patients with a lot of scar tissue in their liver.
Great. Well, we have time for one more question from the audience, and then we will wrap it up. What is the best way to increase awareness amongst primary care physicians so they can catch fatty liver in earlier stages and then triage that out to hepatologists?
All right, let's get short answer so we could wrap this out in the next 4 minutes. So we'll start with Bishoy, Dr. Yani.
Education. So, if we just have to educate our primary doctors about how to screen these patients, about the risk factors, and what would be the best screening method. So that has to be done through webinars like this, through and academic medical centers, educational conferences like noon conferences and whatnot. That would be the most ideal way, in my humble opinion.
Dr. Nadine.
So our practice actually takes MASLD very passionately, and we have the free fatty liver program, and we tend to reach out to all primary care practices. No referral directly needed. There's no cost to this free scan, and so patients can come in and they can actually self-refer to get a baseline FibroScan, and that's one way we're trying to align with PCPs in trying to identify those patients that may need more help, more dedicated help. So that's just something that we've done. But in general, I do echo what Dr. Yani said also, like having these meetings and these conversations, maybe even quarterly, kind of saying, hey, have you looked at your diabetic population? Are you sending these people or screening these people for fatty liver?
How do you gauge their attention? I mean, I know for my primary care provider, he's rushing in and out to see me.
Yeah.
To see so many patients. So how do you increase their interest in learning about fatty liver?
When you take the burden away from them, I think when you say, hey, if you see a diabetic, next time you see one, just pause for 1 second and think, should they be looked at for fatty liver? If so, just send them over our way. And then maybe using more, people in mid-level positions or early training positions to kind of see those more complicated diabetes patients and taking the extra step that they may not have to identify that patient population. I think it's really important. I think that's going to go a long way. And if you start with one cohort and address that, then you can start looking at other cohorts as well. And it's in your flow for your visit, whereas maybe before it wasn't, and you're focused on the presenting problem.
Ed, how?
I agree with what everybody said, and I think maybe even a simpler way to get the message out is, I know like Epic already includes a FIT4 as part of the lab. So I think if they see any abnormal liver enzymes or an abnormal FIT4, that should maybe hopefully help them trigger a referral to a hepatologist.
Very good.
Great. Well, thank you all so much. This was really a fantastic roundtable, and we hope everyone learned something new about this very important topic. And we do realize 1 hour is not nearly enough time to discuss MASLD-MASH in depth, so hopefully we'll visit the disease again soon. It's important to note that our presenters are here as volunteer physicians. They care deeply about our liver patients and are sharing their expertise with all of you in support of our efforts in helping liver patients and raising awareness of liver disease. So it's our personal heartfelt appreciation to all of you for your kindness and compassion. Thank you, Dr. Ayub, for your excellent presentation and for stepping in as moderator during the roundtable. We're honored to have you with us tonight.
Thank you. It was my pleasure. It was good seeing everyone.
And thank you, Dr. Mina. Your insight into MASLD in Hispanic and Asian communities is great. And we hope to talk more about MASLD in the near future. Thank you, Dr. Yanni. We truly appreciate your support and collaboration with us. We're thankful for your participation. And thank you, Dr. Nadeem. We hope to have your participation in our future webinars. And we also want to thank Madrigal Pharmaceuticals and Global Liver Institute for their educational and patient advocacy grants and for sponsoring this event.
I guess I'm back, hopefully. Please join us on September 21st for Walk for Your Liver, Los Angeles in Santa Monica. This is our annual walk in support of liver patients. During the walk, we will feature many liver patients as they will share their liver journeys stories with us. There will be refreshments and children are welcome, music, dancing, balloons, everything is available. Liver Health Foundation will host a special webinar on a rare liver disease called Wilson disease. This is a significant health consequences this disease has. The webinar will be on June 20th from 5:30 to 6:30 p.m. Please join us. Visit our website so you can register. Our speaker at Wilson disease webinar are Dr. Jeffrey Kahn from USC Keck School of Medicine, Dr. Mohammad El-Kabani from UCLA, and Dr. Haider Jamal from Providence St. Joseph Heritage Medical Center. We thank Orphalon Pharmaceutical for supporting this rare disease webinar and we hope that you join us. Liver Health Foundation is on all social media, so please visit us, like us, and visit our website because we do all of our announcements on our website as well as our social media. Thank you for joining us this evening for this important webinar. We hope to see you at our upcoming webinars and our walk in Los Angeles. Happy Father's Day to any man who has ever cared, cherished, and loved a child. Be well, stay safe. Thank you, and good night.